And can you describe for us, let me start with critical care medicine. What is critical care medicine?
Critical care medicine is the branch of medicine that really specializes in taking care of patients with diagnosing and treating patients with life-threatening diseases that often require sophisticated types of care, including sophisticated invasive monitoring, patients who need mechanical ventilation, who need to be on a respirator. But it also involves a whole host of disciplines. So we in the ICU care for patients with a variety of different problems that leads them to being severely ill. And our efforts are always to revive them, make them better, and get them through that difficult time.
What is, when you say invasive, was it invasive monitoring? Was that the word?
Right. Invasive monitoring can involve very basic things like having patients on continuous EKG monitoring their blood pressure, their heart rate, their oxygen saturations. But it can be more aggressive than that, and it can involve having patients on the ventilator who have respiratory failure, unable to breathe on their own. And can involve placement of a variety of different catheters to monitor what we call their intravascular pressures, to monitor the pressures inside their heart chambers, for example. Other procedures that are often done include things like putting in tubes in patients' chests to help relieve problems that resulted in them being on the ventilator to begin with, such as fluid accumulating in the space around the lungs or development of lung collapse. So it involves a whole host of disciplines. So as an intensivist, you not only have to be very familiar with cardiopulmonary physiology, so physiology that pertains to the lungs and the heart, but you really have to be comfortable with taking care of critically ill patients in general with a whole host of problems, with a whole host of organ failures.
And in the critical care unit, are these patients long-term patients in the critical care unit? Does it vary, or how would you describe that?
It can be variable. Now, where I practice is we have a younger population in general, patients that have had no access to health care and to insurance. So very often we have young individuals that have never seen a doctor or let their disease process progress, and they come to us, and because of age, often they have the capacity with our help to make it through, and sometimes the course can be short, but at times we have patients that require longer-term stay in the ICU, and one of the main reasons for that is patients require long-term need for a ventilator. But often, over time, patients declare themselves. They either get better, or if they don't and everything else stabilizes, very often we can transition them by placing a tracheostomy, which is another one of the procedures we do in the ICU, and transition them to a lower level of care. So to answer your question, it's variable in terms of how long patients stay in the ICU, but in general, our goal is to try to get people out as soon as possible.
Thank you, Doctor. And now, you also specialize in pulmonary medicine.
That's correct.
And can you describe what that is for us, please?
Right. Pulmonary medicine deals with a variety of problems that affect the respiratory system, the lungs, and it can deal with problems that are pretty straightforward that we see in the community often, like asthma or emphysema, to a variety of different types of what we call interstitial lung diseases like pulmonary fibrosis or pulmonary hypertension. But it can involve a lot more in-depth diseases that most people may not be as familiar with. It ties in very well to critical care because in the intensive care unit, very often we do see patients that have respiratory problems, and the understanding of respiratory or pulmonary physiology is very essential, especially when we care for patients on the ventilator, because they go very hand in hand. But just to let you know, you can become an intensivist or a critical care specialist without the route of training that I did, which is through internal medicine. It can also be obtained through anesthesia, People that do anesthesiology training can go on and further subspecialize in doing critical care anesthesia, as can surgeons. So there's really three routes to becoming an intensivist. The route that I followed was doing internal medicine and doing a combined residency in pulmonary and fellowship, in pulmonary and critical care.
And do these fields, both critical care medicine and pulmonary medicine, require, because of the nature of the treatment, you to have knowledge in the field of sleep medicine?
Well, that is an optional thing, and there are those. There are actually programs now during the last 3 years that actually have there is a special training for people that have trained already in internal medicine to get further subspecialty training in sleep medicine. So it is actually a fellowship in and of itself. During the period that I trained, the sleep medicine was part of the 3 years of fellowship training that we completed, and we sat for. People like myself who were interested in the field took the boards and sat for the sleep medicine boards and practiced sleep medicine. And
again, if you could describe generally for us so we know about what you're speaking, what is sleep medicine?
Well, sleep medicine is rather new. It's been around for a while, but compared to other disciplines in medicine and other specialties, it's kind of new. But it deals with problems that relate to sleep. I think the public can all appreciate sleep apnea as the most common problem that we all hear about. People having problems with sleeping and their airway closing up because of the tissues relaxing during sleep. But that's really only the tip of the iceberg. And although it's very prevalent in sleep medicine, we also see a whole host of other disorders, from problems relating to insomnia to problems related to circadian rhythm problems, patients that have problems with the part of their brain that sets their sleep-wake cycles, to problems that result in seizures at night, parasomnias. There's a whole host of problems that we deal with in sleep medicine, but really the ones that people are very familiar with is often things like obstructive sleep apnea or insomnia.
And are you in fact board certified in these fields you've mentioned?
Right, I'm quadruple boarded in internal medicine, pulmonary disease, critical care medicine, as well as sleep medicine.
Now, Dr. Kamangar, do you offer your services to the California Medical Board as an expert reviewer?
Right, I've done that for the past 2.5 years or so. I see that as a way of serving as a peer reviewer for my peers, to really maintain the level of care and professionalism, especially as it pertains to my fields of expertise within California.
And as a medical reviewer for the California Medical Board, did you conduct a review in this case involving the treatment offered by Dr. Conrad Murray to the decedent Michael Jackson?
That is correct. As a reviewer for the California Medical Board, often get contacted as to assessing a case and really giving an objective, unbiased opinion as to whether there's been any deviations from the standard of care in the management of a process that pertains of a patient that pertains to pertains to my specialty, basically.
Thank you. Before I get into that, as it relates to critical care, by the nature of critical care medicine that you've described, that involves the intensive care unit, the ICU?
That's correct.
And are there issues that arise as a result of the conditions or the conditions of the ICU that makes sleep medicine issues arise in that particular field?
That is very true. There's an inherent problem with sleep in the ICU. Patients that we see in the intensive care unit sometimes can be the extreme latter parts of their age. As we see patients get older, we're seeing more patients in the ICU with latter periods of their disease, and they naturally are more susceptible to the effects of just changes in the circadian rhythm.
Just let me stop you that, because you mentioned that earlier. What is the circadian rhythm?
Basically, there's a part of the brain that is responsible for secreting hormones such as melatonin that basically regulate when we're supposed to go to sleep and when we're supposed to wake up. And exposure to sunlight is a very critical element of that. And one of the therapies for problems related to that are daylight. And hopefully none of you will end up and be in an ICU or see an ICU, but just to give you a picture of what a classic ICU looks like, there are really no good-sized windows in most ICUs, and if there is, there's a slit at the very top. So patients that end up in the ICUs, one of the first things is that they lose that normal sleep-wake cycle. They lose that circadian kind of chronicity that they have, where they're used to waking up in the morning and being exposed to light and knowing the difference between day and night. That doesn't take much to throw some individuals that are more susceptible, like elderly individuals, particularly if they have an underlying problem like an infection or some underlying process that's led them to be in the ICU, to really develop problems with insomnia and sleep. And a major issue is the phenomenon called sundowning or delirium that occurs. And there are many contributing factors, too numerous to talk about here, but things such as pain, the underlying infections, the metabolic processes that are going on, and they all culminate and result in this problem and difficulty with sleep. And it can be often confounded with the delirium that exists in some of these patients as well.
Now, as far as the use of propofol, is that agent in the critical care unit?
Absolutely. We use it on a daily basis on multiple patients at a time in the intensive care unit.
And do you personally have specific training in regard to the administration of propofol?
Absolutely.
And could you describe that, please?
Well, our role is as intensivists or critical care doctors is slightly different than, for example, anesthesiologists that are another group that are obviously very well trained in the use of propofol. The use of propofol in the intensive care unit from the perspective of a critical care physician is for induction of anesthesia when you want to place a artificial breathing tube, which is known as an endotracheal tube. So a patient that we feel can no longer breathe on their own, and modalities that we try to implement to try to kind of get them better have failed, such as a non-invasive modality. Sometimes we need to put a breathing tube in, and that requires giving them propofol in order to basically cause them to anesthetize them and sometimes deeply sedate them, as we call it, to allow for the placement of the endotracheal tube. We also sometimes add other agents when we're doing this in addition to the propofol, but it is the classic induction agent that we use. We also continue that drug very often. It's actually the most common drug that we use in the ICU for maintenance of sedation in a patient on a breathing machine. Now, different people tolerate a tube down their throat differently, but most people find it difficult, and particularly when you add an underlying disease process to that, say that they're having really difficulty getting oxygen to them, sometimes you really need to sedate them and make sure that they are compliant and synchronous with the ventilator, and we do that by using propofol.
So use it for a common use of it would be for use of an endotracheal tube to get that actually into the patient.
That's correct. That is in the auspices of where I use it as an intensivist, and I think I can speak for other intensivists. That is the most common use for induction, for placement of an endotracheal tube, but also for maintenance of sedation when a patient is in fact intubated, meaning has a breathing tube in, is